his face.
Well, good morning, everybody. For those of you who don't know me, my name is Deb Woodcock, and I'm the program manager for the DMICE Informatics Discovery Lab, fondly known as the IDL. I wanted to make a few housekeeping announcements before we get started. We are recording this session, so at the end or whenever you ask a question, I don't know what your preference will be as far as whether you want people to interrupt or wait to the end. Please push down the button on the speaker there and just hold it while you're speaking, and that will capture what you're saying. Also, we're streaming the talk live today, so if you're out there in the Twitter sphere and want to participate in the conversation, please send a tweet to OHSU Informatics, all one word, and use the hashtag DMICEConf, DMICECONF. Today, I have the great privilege of introducing Dr. Martha Driessnack. Dr. Driessnack is an associate professor in the School of Nursing here at OHSU, and I had the good fortune to be in an interprofessional education class with her last fall called Narrative and Healing, which was really, really wonderful class. Dr. Driessnack received her BS from the Ohio State University, her MS from Yale, and her PhD from good old OHSU. Following that, she did a postdoctoral research fellowship in clinical genetics at the University of Iowa and the National Institutes of Health. She's well known for her research with children and her emphasis on engaging children early and often in health-related decision-making using child-centered and directed approaches to data collection. One such approach is the integration of children's drawings called the Draw and Tell Conversation, or the DTC. Today, Dr. Driessnack will give an overview of her work and describe some of the informatics challenges that it poses. You probably wondered a little bit when you saw the title how this related to informatics, and we'll make that connection for you. And then at the end, we'll also spend a little bit of time talking briefly about this year's AMIA Student Design Challenge. And the reason we're tying this together is that Dr. Driessnack's presentation we're thinking of using as one of the challenges that we enter in this competition. There may be others, but we can talk about that later. So without further ado, yeah. Dr. Driessnack.
Sure, thanks. And you can interrupt me anytime, push your buttons, or just raise your hand. You push your button on your own. I don't know anything about that.
Well, they have to push the button when they talk.
Oh, that's what it is. Okay, so whenever you can interrupt spontaneously, anytime, but remember to push your button to speak so that they catch. How's that? So what I'm going to talk about is just really a little bit about what Deb said is about my use of drawings. I'm going to give you a little bit of background and then the challenge that I came actually down with in terms of I have this line where I say, and then they just upload this into the electronic health record. And I said to Deb, and then a miracle occurs. And so could you help me with that miracle? So that's really the backdrop to this. So I always start by acknowledging the drawings that I will share some drawings from children. And I do have permission from the children to share that. I don't share drawings that they haven't given me permission to do. So just as a little bit of an introduction, there's this whole emphasis right now on patient-centered care, and I think one of the challenges is around how do we integrate that patient's voice into care, but it's even more challenging when that patient is a child. Children have primarily been seen through adult eyes. So when we think of what we know about children today in research, it is typically from adult proxies. It's not from the children themselves. It could be from parents, teachers, will default right away. And a lot of that is because when we ask children, to tell us something, we use tools that are not appropriate for them. But I'll get into that in a second. Because we use the reason we defer to adults a lot of the time is because we think of children as in the process of being developing. If many of you have taken a developmental psych course, you may have heard of Piaget or Vygotsky or whatever. What we're looking at all the time is children are in the process of becoming adults. Because of that, we think of them as human becomings rather than as human beings. So we figure we can't really get any good information from them until they can talk to us like we talk. So there's this kind of like developmental lens that we see them through. And because of this, all the tools that we have are really not child-centered. Instead, they are adults. So the tools that we have, even in research or in practice, are all adult-developed. They were developed with adults. And then what we do is we think, oh, we'll use them now with kids. And we'll just put simple language with them, or we'll add a little picture to it. But what we don't realize is just even adding pictures to things, it may make it child-friendly, but it does not make it child-appropriate. Because children don't know seriation skills. In other words, a rating scale, 1 to 5, where you say, what, you tell me this, and this is the well-known pain scale. Tell me, is this the worst pain you've ever had? And children will give you all the way to the end. Yes, it is, because it may well be the worst pain they ever had. And we instead look at that and think, they have no idea. This is not pain. Or this, or we'll discount what they say. So they don't know how to put things in order yet about worst. They can only think in 3 categories up to about the age of 10. So anytime we use a sliding scale of greater than that, children will end up going to one end or the other and never riding in the middle. So they don't have that seriation skill. The other thing is when you look at this requires the skill of empathetic recognition. In other words, you have to be able to look at somebody else and say, oh, that's what I look like when I'm feeling painful. And children don't have that skill till they're about 10 years old, fully developed. So we're using tools, and I'm going to come back to this pain because it's a lot of what I do, that are inappropriate for children. And they get even better because, when you show these, this is the Oucher scale. When you show these to kids, and if you look closely at these pictures, the kids will say, oh, I don't want, what's going on with those kids? They're like, what is that? And even worse, if we try to use the adult scale, they'll think, oh, get rid of what's the matter with that man over there. That's not me. I can't do that. And they'll immediately like to be replaced. They'll tell me when I have this content expert panel. When people do expert panels, they always have people in the field. I have a content expert panel that is all kids. So they rotate through, and I'll show them a tool, and they'll say, oh, get rid of that drawing, because that's creepy. And I said, well, it's very appropriate, of course, for adults because you've got all the dermatome, everything's all separated out, and we can quantify it. But for a child, they're not going to fill it out. And especially kids with headaches would never have filled it out because they don't like the oversized head. So right now, part of the impetus for this talk or paying a little bit more of attention to kids is there is a current NIH initiative called No More Hand-Me-Down Research. Now, mind you, the energy behind it is coming from medications. Like, in other words, most of the medications we have for children have never been tested with children. And so they're trying to engage children in research, get people to get children, and they now require us to have children in research. And you have to make a pretty good reason not to have children in research, especially if you're developing something that's going to affect them. The problem is they are working really hard to do this, and people are actually engaging children in the research, but they're still using these tools that are not appropriate. So most of the tools that we have for children have not caught up to this invitation to include children. So there's this movement now toward the development of what we call child-sensitive tools. All right, so these are child-directed tools. This is where you shift the power from the adult to the child, and you get the child. You capitalize on the child's cognitive and behavioral strength rather than adults. And what we have found is that when we do this, we not only get more information, but the information we get from kids is very actionable and helpful. And one of the examples is drawing. All you have to do is ask a child to draw. If I went into a kindergarten class right now and I said, who here is an artist? Everybody in the class would raise their hand. Now, if I ask you, you probably have been having beaten out of you if you're an artist or not. And usually that happens by about the 5th grade. But under that time, in those 7 to 10-year-old age range where they don't quite have the verbal capability, they are still organizing all their thoughts using sensory cues rather than semantic or word cues. So they're in that development. And you started that way too. So even to this day, a certain smell or a scent or a feeling will take you right back to a place that you had. That goes back to this time. So this is their strength right now. So when you ask a child to draw, it gives them a moment, sort of a parallel space for them to organize their thoughts before they talk to you. Are you with me so far? Okay. You guys are all very... I'm used to kids like fidgeting and throwing things. Okay. And yeah, feel free to fidget, pass notes, those type of things, but I often interrupt and take the notes and read them aloud. So. But anyway, the highlight, the caution I like to say right up front is that children's interpretations are different. So just asking the drawing and taking the drawing from the child is still is not appropriate. You have to get their explanation. The drawing is there for them. It's not for you to interpret as much. but it's there as a prompt for them. And it, you can look at it. It will affect you, some of the drawings, but just know that the interpretations are different. And I often use this drawing, which is from the book, The Little Prince. And it's just a great drawing, but it's probably the story of a little boy, if you don't know it, who is a prince of a planet, his whole planet or whatever. I always say it's every child's story, because every child is king of their own domain. If you're not a parent, you will find that out soon enough. But what happens is he goes to adults, a series of adults, with this drawing, and he says, I have a really big problem. And they are like, that's a very pretty hat, go away. Or like, go away. It's like, and they've interpreted this drawing as something. But if you look closely, there's actually an eye here at the end of this. And really what this is a boa constrictor that has swallowed an elephant head first, and both of them are still alive and they don't know what to do. Now, this is not a real problem, and you're saying, like, this is what happens with children, it's sort of fantasy. But what it is a child coming to an adult with a problem and asking for help. And they are pushed aside because we didn't take the time to understand from their perspective what that dilemma was. So are you sort of with me on that? So it's often what I use, that there are whole books about this, and people quote from this book all the time. But I love to show this drawing for that reason. In real life, it's the same thing. So I caution that I'm going to tell you the use of the drawing, but the drawing will actually affect you, but at the same time, you will interpret the drawing. You'll look at it and you'll say, like, you look at this, what do you think's going on here?
But I know
Watching
that's
too
wrong.
many of,
You know, but that's what I think. It's
Yeah.
like,
Yeah, you sort of notice the eyes. What do those eyes sort of tell you? Dizziness, or focused really in, and notice the blood coming out of the mouth. So that could be the vampire of the teeth or whatever. Typically, it's a pretty angry, look to it. And the story of this is I actually found this at the airport, all balled up in a wad, and I was sitting at the airport with my kids, and I opened this wad of paper up, and I think, oh, look at this. And it was right after Columbine, and I'm thinking, oh, angry. And all of a sudden, and my kids are like, Mom, don't look around, don't do anything. This is not, you're not in practice right now. They're like, we're going to Washington right now. And I'm thinking, and all of a sudden I hear this, Patrick, come over here. And I'm thinking, Patrick, do you see Patrick? And I'm thinking, Patrick. So I'm like, So I just go over and I said, I said, oh, I found this. And he goes, oh, yeah, that's my drawing. And I said, well, as usual, you take this sort of stance of not knowing what it is. And I just couldn't help myself. And so, and he says, oh, yeah, I don't need that anymore. And I said, why is that? And he said, because I already lost my tooth. So do you know that feeling right before your tooth comes out where it was hanging? Take yourself back to, like in that one moment, and that really actually captures it. But how quickly we can misinterpret something if we don't take the time to listen to the child's drawing. So there he is. So I offer every child the opportunity to draw, especially kids between the ages of about 5 to 10 in particular. And after that, children tend to sort of say they can't draw, or it's like an adult response, and we do other art projects and stuff with them too. So art in any capacity is helpful, but I'm just going to focus on the drawing today. What I like to say, it's no child left without crayons. And then I make sure that I listen to their story. But at the same time, I recognize what my response to it was. So you have to recognize that, check it, and go on. So sometimes, I did a lot of work with the kids. This is after 9/11, so these are the Twin Towers, and this is just one of the drawings. So we were part of the Children's Television Network a long time ago, so we would come in if there's a big trauma. We did it with the hurricanes and the tsunamis and stuff. And it's a well-known way to help children, but this is a drawing that everybody was going to use and put on the front of the New York Times. They thought it was so interesting that the two buildings were crying until you heard the child's story. And this is one of the kids who was actually in the elementary school where they watched the people jump out of the building for a long time before the teacher finally got herself together. And I don't blame her at all, because I think it was probably shocking to watch people jump out. And then they finally closed the blinds. But if you notice, this building is crying, but what it is crying is people. See them down here? So they said, so they ended up, once they heard the story of the child, and the child did not give them permission to do it, and they honored that. So you can do it in very dramatic things, or like I love to show this drawing because it's like everybody cringes. when they see it. And I think I drew this out for you guys. So this is a child, and I got called down to the emergency room and said, this is a kid with trauma, abdominal trauma, chronic abdominal pain, but had some other things going on with them. And they said, they asked the child, because they knew I was coming, they said, well, you have to draw a picture of what it was. Could you draw a picture of what caused your pain or whatever? And this is what they drew. And everybody had a heart attack. They were like, oh my gosh, we didn't know, or whatever. They're going through this whole thing. And I looked at this drawing and I said, I know what you guys are thinking, but this detail right here is bizarre. Nobody would spontaneously, a child is not going to draw the raphe going up the middle of the, and I'm thinking, what the heck is that? Of course, somebody walking in right now in this drawing is going to think, what is going on? Maybe I'm in the wrong talk. But anyway, so when you asked the child, I just said, could you tell me what this is? And the child said, yes, those are my scissors. I was using the wrong scissors. And if you look at it, it's exactly what it looks like. But again, it's this caution about getting the story with the drawing, that the drawing is the facilitator, and the drawings can be very complicated. So you might look at this. This is a child with chronic pain, abdominal pain, missing school, and we're trying to figure out what the heck this was. So I said, could you draw a picture of yourself? And this is what they do. And I thought, what am I getting now? It's got King of the Jews on top of it. It has every detail. If you know the Christian story, this is Jesus on the cross with the nails and the details and the slit on the side. It was really detailed. But if you notice one thing in particular, this Jesus, I didn't notice right away, has a little bit of chestiness. And this was a child who had gynecomastia and was really suffering with that. And this is his only image of suffering that he knew, and then his way of telling. So he was just talking about. So it can get complicated, and it can take you in a totally different direction. Everybody was working this kid's up for Hirschsprung and everything else with chronic abdominal pain. Here's another chronic abdominal pain. So you just draw a picture of yourself, and this was a drawing. So you can tell that in my office we have paints, and it can be elaborate, but you don't need to have all of that. And this is just a child whose parents had recently divorced, and he's in 2 houses, 2 separate, and that's what he ends up doing. And they can be really simple. So here, chronic abdominal pain, and you look at it, and what might you think is going on here? Fell down the stairs and maybe pushing or something, so the simplest of drawing. And actually, this is a little child who's trying to keep his grandmother from going to heaven. So his grandmother's in the home, and she's dying, and he doesn't want her to die. So he's staying home and creating papers. So I'm just going to give you a big, difference in terms of what you can get. You can get very specific. So those were 3 kids with chronic abdominal pain. Here's kids with headache pain. So you just draw a picture of it. Here it is, pretty clear. They've been huge studies about how this is as good as a lengthy neurology exam. That you can send this. They did hundreds of drawings to hundreds of neurologists, and they were able to differentiate between migraine and tension-type headaches just on the drawing and the child's story alone. That it's a great diagnostic tool and helps get the child on the right track early on. So I started to do one study where we had these drawings, and then I contacted about pain. We were looking in particular about kids with chronic headache pain. And there's a whole emphasis on why we were doing that. But then I ran this by this group of expert panel, and they said, there's an app for that. What's this piece of paper drawing? We'll draw right on our phone for you, or right on our iPads, and they have their iPads with this little hand glove on the other side that they just show you, I don't know. It's very, and they said, you should be using the computer. And so I switched, and I started to do headache drawings with the computer. And said, draw a picture, and of course I'm telling them, you can make this bigger and enlarge it and draw this in detail and smaller. You can put it in the whole context of the body. And they're like, yeah, we know that, lady. That. And I said, it's called a pinch mechanism. And they're like, whatever. So I'm like explaining this to them, and they're just very spontaneously doing this. So now I have kids drawing on their computers, on their iPads. They can do it on a piece of paper, or they can do it on the computer, and they can send it to me. They can do a screenshot of that, and then they talk about what it is. Could you describe this for me? And the drawings can be quite simple. So this is a child who draws the headache, and this is the pain. What if I went back to that one tool and said, here's a drawing, could you describe it? And could you say, is this a pulsating? The child would not have answered that. Wouldn't have come up with the word pulsating or a throbbing pain. They wouldn't have come up with that term. But that's exactly what this child described, that this is one point in their head, and this is what happens. So this is the point all blown up, and it's big. It goes boom, 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 smaller than big, boom, 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 boom. So it's a very clear drawing. I can take that drawing and then put it into my characteristic terminology, but I could never have got a child to circle that word, at least at this age. Are you with me still? You guys are pretty flat. Okay. All right, so here's another. You can just see with the computer. So this is a free drawing by kids where they blow it up. So here's the drawing on the left-hand side, and then I have zoomed in where they have zoomed out on the head. And this is where they describe their headache as tectonic plates. And I'm like, tectonic plates? They go, yes, 2 tectonic plates rubbing together. And you know what happens right before when the whole thing explodes. And I'm thinking, okay, this is like this pressure sort of. And then what's really funny is when I was doing this as part of research today, there's this lightning over here. The parent was just outside the room because the children are given the choice whether their parents stay in the room or go outside. They all send the parent outside. It's sort of funny. And they usually say, and let me know if you need to go to the bathroom. It's a control thing. But anyway, the mother was outside the door and said, tell them it's like a lightning strike. That was the mother's term. And so he dutifully drew the lightning bolt and then went back to his tectonic plates. So that's there over on the side. And then down here, in the stomach here, this is blown up. He said it's like boiling water, and that's what that is, like, the boiling water. And you can sort of feel that sort of hot, or whatever sense that they have. So their descriptions are very good, but they would not have been able to use our words to do it. And this is just another example, and I'm trying to emphasize how easy the drawing is, how simple the drawing is, but how rich the story then can be. And this, you can see exactly where the headache is. That can be blown up, and it was all arrows pointing in. And then in the stomach, it's like you drew a knot in his stomach. It's like there's a knot right in his stomach. So it was a great terminology. And here's the most simplest drawing of all, where they drew it out, and then you see this little arrow down here. This is his stomach, and what he's describing here is that when this comes, I always know it's coming because down here first I get this thing that's going to come up and shoot out of my mouth. It starts here and then goes to my head, and then when it gets to my head, then I vomit. So it's like that aura beforehand with a pre-nausea. So you get a whole picture with very simple. So the drawing itself can be very simple, but the story that accompanies it is rich. And what's most interesting to me is that when I show this drawing to the child 6 months, 1 year later, they go, oh no, this headache's different. So they know their own drawing really well, as opposed. So it's important for me to keep that drawing and what they told me. I usually keep a summary of what they told me, and I have that readily accessible to me in a hard copy, which is my challenge here to the informatics people, is how can I get this into the electronic health record? So that's really my challenge, is that I use these drawings all the time. I want them readily available, especially with kids with chronic pain or ongoing symptoms. I try to get pediatricians and nurse practitioners in the outpatient area to use this. Get a child who's in a rural area to describe something, draw a picture of it, send it in from home. These are the kind of the things that I'm looking at, because for me, a picture is totally worth 1,000 words, but only if we listen to that. So this is like what happens, and this is the age group that it works for. And oftentimes we look at this age group and say, they're not going to be able to give us anything. We have to go to the parent. But we can get an enormous amount of information that's very comprehensive and actionable for us. And I think it makes our diagnostic abilities and our ability to put the patient at the center, that child at the center of their care, and engage in the care. Because when I pull out their drawing the next time, they go, oh yeah, now this has changed, this has not changed, or this, and they're very oriented to that. And they love seeing that you kept their drawing, and it's one way to engage them. So my particular challenge is, and what I came looking for the informatics folks for, was I say, when I'm writing grants and I'm trying to get these things funded, some of the research, or this is an intervention, I say, and then you can upload these pictures directly into the electronic health record. And that's when I turned to Deb and said, that's when the miracle occurs. How can you upload this and make it readily available to me in the clinic, like when I'm seeing the patient, or on the floor? How can a child from home, so it could be a hard copy drawing, because I often will get a kid to draw right on the examining table. I have the examining table there, that the white paper that's there, they can draw right on that. Some children will prefer real art paper if you want them to be an artist, so I always make sure I have really good quality art paper. They do not like drawing on paper that has lines. They're like, what is that? You're not really serious about my drawing. I like texture to my paper, So some choice and good tools, and I have this advisory group who's told me exactly what that should be. No broken crayon. No, it's not nonsense. They come now with roll up, so it's an eternal sharp point. You wouldn't use a not sharp point either. Come on now. We gave your pencil broken in half, so I'm thinking, fair enough. So I have sort of a very simple art kit with kids that I use, but it could be a hard copy. It could be a digital copy. It could be on an iPad. It could be on a phone. Different types of tablets that they use. Whatever it is that they have, that they can draw on, I want to be able to capture that. I want to be able to upload it into in some, whether it's from home or in the clinic. So if somebody sent that to me, yeah?
May I ask some questions?
Sure. Oh, yeah.
So you've already talked about narrative and the importance of context. So I'll just ask you kind of a list of different sort of requirements here. The first one is, would you prefer the narrative to be embedded or viewable at the same time as the image, or would it be acceptable to have the narrative as a linked note of some kind?
It could be linked, but I don't want it not to be there. The importance of it is that it has to be there. So it could be linked, but the danger of it just being linked, giving people the option to look at it, would be that they might interpret it themselves. I can tell you the child doesn't need the link. For me, it could be, if the picture's there, it would be nice for it to be available without the link, because I could say, this is what you drew the last time, but then I would say, and this is what you said. This is how you described it. And most of the time the child will say, I don't need to know your words. I know exactly what was going on there. They'll know their own drawing. So that probably doesn't exactly answer that question.
Oh, actually, that's perfect.
Okay.
And sort of a related question is whether you would ever want to capture audio or have them speak in their own voice.
Yeah. So when I do this in research, I embed Camtasia into the computer, and I capture their voice entirely, the entire story. That's a big file. Is it totally necessary all the time? I don't think so. I can actually pull a couple, and what I'm trying to do is make this efficient for the clinician, for the researcher, but mostly for the clinician at that end, so that they would actually use it. And if you have this big file that you have to stop and then listen to, it's nice to be able to capture it. In research, I always do that, and then, summarize it. So it's sort of like being able to capture, I should say, the essence of that narrative, or the child's words or the child's descriptions. It's always interesting to me in patient-centered care when we do SOAP notes. Have you all heard of a SOAP note? I remember what the S stands for in a SOAP. So it's when we do subjective, we have the subjective, objective assessment plan. That's what they say. And the subjective is usually one line. If you're lucky, a little thing in quote, has headache for 2 weeks or something like that. We give a lot more credence and attention to the objective and the assessment in the plan. This is really to beef up the subjective part from the child's point of view. And I don't know how it gets into the SOAP note, but it's that piece to capture in their own words, but not the whole thing. You know Camtasia, right? So we use it for lectures and things like that, but it's really easy to embed. But it would not be necessary, I don't think, overall, excepting from home, maybe, if you were recording something. So, because what you don't want is the child to be able to send this to you from home without their story, or they can send it to you and then they'd have to talk to you. But there must be like an accompanying sticky note or something on that drawing. It should never be in isolation. That's a real caution for me, or the real no to have a drawing by itself. Does that help? You have more on that list? Not yet?
I do, but
So this is really, Deb asked me, what is it that you need? And I said, when I actually stopped to think about it, what I need is ready access at the point of care to this drawing so that I could show it to a child. So, and for retrieval, so I can show it to them and going forward at the next visit, but also easy upload if they did it right there in the office, or at the bedside in the hospital. So it's not, I say clinic, outpatient, or from home, but this could be a child who goes home from the hospital too. And I give you examples of pain because I just pulled out one thing. You heard that I have a background in clinical genetics, so I also use these drawings to explain genetics. We get into the whole Mendelian, of course, Harry Potter helps me a lot with that because the children will just tell me, do they have the magic chain or don't they? Are they squibs? Are they, they can explain, incomplete penetrance and, all sorts of things with Harry Potter, so I have a lot of help. And evidently SpongeBob SquarePants has also done a little lecture once. I have not seen that one. But, so I do body outlines. Children will tell me about where they think their illness comes from, how things are inherited in their family. We do 3-generation pedigrees doing this whole thing. It's really a tool that's wide open. People use it a lot with trauma. I'm focusing here on pain because we only have this one pain tool, and it really looks at, it's really not an appropriate age level tool, and it only looks at intensity. It doesn't really describe the pain. And my emphasis on pain is because children who have chronic pain end up as adults with chronic pain, and that's a huge impact. It's a huge pain. And maybe if we paid more attention when they were young and addressed their pain early, they wouldn't turn into those chronic syndromes. I don't know that, but that's part of my emphasis. Okay, so this is really what I'm looking at, the ability for kids to send it in from home. I mean, it might be nice if they were in the school nurse's office and could describe it too and send it in. I had talked with Deb at one point, how I can send something in on my chart. Does it come in through my chart? How does it get to my chart? To the, does everything have to be uploaded into the record? I don't know. We talked a little bit about, the radiologists, they get to look at x-rays at home. Why couldn't we be looking at children's drawings at home or something? Is it as simple as that? It's just, an x-ray with it. But, unfortunately, when we send the x-ray, we usually don't have a little narrative that goes with it. At least last I knew there wasn't something. So that's really what I was looking for. And then any questions that we have. And then there's one, should I put that last slide up or you want to talk about that? Yes, so, and this is me, by the way, in case you don't see the resemblance. So the kids often will draw me and just say, this is a much better picture of you than you actually look. Maybe you should put this out because they don't like the drawing I have on the website. You should put this up instead. Like, you're looking better here. And I'm thinking, thank you very much. So you have to really have a centered self when you deal with children. Yeah.
Yeah, really interesting. One of the concerns that we hear from clinicians is, concerns about overload of data from patients. Now, granted, this is not a massive amount of data, but on the other hand, I could see situations where this maybe comes out of the blue, via delivered asynchronously, so not when the child's right there, and a clinician not knowing what to do with it. I guess it gets to a larger question about have you or has anyone done any work on the validity of what these drawings mean, and how clinicians should be expected to react, going back, if you're sitting in your office and some child had just uploaded that scissors picture, and you weren't even seeing the patient that day, just some of those sorts of issues.
So the picture should be solicited, number one, by the, in other words, if somebody says contacts from home, I can give an example with the chronic abdominal pain or something. Listen, the kid's back home again is having another headache, and this one seems different or worse. And I would say, could you have them draw a picture and describe it to me? That would be something from home. I would not be looking for spontaneous things coming from home. They usually are solicited as part of, tell me what that's like. Or if you're saying a patient is, writing in and saying something. I will tell you that the term validity, is often brought up with, how valid are these? How valid are children's stories? How valid are the drawings? The drawings by themselves, people have analyzed drawings for years. That research started in the psychopathology literature, and so we're always looking for something in them. The validity of the drawing itself is not the drawing you can see is not what I always think it is, so very invalid if you're looking at my interpretation. I always say that the drawing is there to facilitate the telling of the story, and it's used as the background to the narrative in the front. But that said, there have been studies that have done where they actually had children draw and tell following an event to see how valid the things were, and they were extremely truthful. Like, in other words, they said, these are exactly the facts. This is what happened when they did it. So they did it, and most of that research has been done in New Zealand and Australia. So they actually looked at it. So first they looked at, oh, look, you got so much more information. And then they said, well, more is not necessarily better. Kids can go off on big stories. Not that adults cannot do that either, but we give adults a little bit more legitimacy. And then they said, well, let's just see if it's actually, can they give us truthful or valid information and reliable over time? And they did do that with set things. And so that has been shown. There's been meta-analyses done in terms of amount of information that comes. So it's really, the drawing is a challenge because it's nice for the drawing to come with the narrative, but the drawing is a facilitator to the narrative. It's a better way to get information from the child. So I wouldn't want a spontaneous drawings coming in, especially not that scissors drawing. That would just, and there is a caution about that, but usually it's how do you do this so that if you needed information from the child on a symptom, you could have them draw it and then tell you about it. Instead, we ask parents. Now, you could ask the parent to to get it from the child and then tell you. That would be a default for most clinicians because we're more comfortable dealing with adults. But I can tell you, any study that has the adult description of the symptom and the child description of the symptom, the adults and the child do not agree. And I often show that just the lightning bolt versus this. And it is, and what we do is we have deferred to the adult description of it because we think of them as more legitimate. Does that sort of address your question? Okay. But I don't know. I suppose once you open it, and drawings, you might get all sorts of stuff coming in, and then it's like, what do you do with this? Yeah.
First, just a comment that what you're asking for, at least in EHRs I've worked with, you can do. Most EHRs I've worked with have the facility to scan in data, so you have to scan it in. You can do that. And when you scan in a document, you put a cover page on it saying, here's what it is. So that is relatively easy to do. The problem I'm thinking about, if I don't know how to do it, is the voice. Mm-hmm. That the voice input, just taking the time to listen to the voice. Bill, no, it's taking the time. It's the fact that, if I've got 5 minutes to prep, mm-hmm. I'm not going to spend 3 minutes listening to a kid talk. I'm sorry. I probably should, but I don't.
No, and clinicians will say, I don't have time for this. Or most of the time they'll say, I'm not an artist, I don't have time for this or whatever. But, what happens is when you look at time, this really actually takes very little time to ask a child to draw. You could be getting something else, doing something else. And then to listen to it, the explanations can go on, but rarely do they go on more than, 4 minutes. But it is a lot of time. But we do listen to patients. And so this goes back to my, the challenge when the patient in this patient-centered care equation is a child. That patient then comes with parents. And unfortunately, sometimes they come with 2, 3, 4 parents, each with their own story.
And that's the issue, I think, with the sending from home. Yeah. Because I have worked with stuff that's come from home, and the parent basically directs what goes in. At least we'd send.
And there would have to be that, the child can't directly send in. But again, this is an engagement of the child's family in the care, and it would not be open to everybody. It's a tool to use purposely, just like you wouldn't give everybody a pain tool, unless you were trying to get more information about that. Question.
Well, on the technology side, first of all, I was thinking fax as well. The catch is when I see people scanning, at least in small clinics, it's black and white. Mm-hmm. And what I'm getting from you is there's a lot of richness in the color, maybe even size, scale, and texture, that there's some nuance to this that just scanning it as a document may lose. Mm-hmm. So scanning might have its challenges. Okay. Sure, photographs, absolutely. So, Bill, the handheld.
The kids told me they downloaded an app for me called Genius Scan. I'm just saying, they just said, this is what you need, lady. Scan this right here, upload or whatever.
And the nice thing about Genius Scan is that it does the cornerstoning. So if you hold the camera at an angle, it can adjust it so it's flat. So it kind of gives you a chance to keep the aspect ratio of the image, even if you take kind of a sloppy picture. So Genius Scan is a great idea. The other part, though, are these behavioral health records? Are they clinical records? Is there a concern where in the record they go and who can see them?
Yeah, so you always, when you're dealing with children, could get a drawing that has implications legally in terms of child maltreatment, or abuse, neglect, even when you least expect it. I could be doing a headache study, and all of a sudden what I'm finding is that, this chronic headache, there's an underlying story. So we have, I always say in the backdrop, there's this little legal caution about if you get something in a story that has any suspicion of abuse or whatever. The place in the record for me is in the, depending where you are. So if you're up on the unit and you're doing this at the bedside, it would be nice to have that there and available to pull up for the child to respond to in the future. Like if they did some drawing on a computer or a tablet, and then you come back 2 days later and you say, is this still what's going on? Is something else? Can you describe it? Add to the drawing, give an update or whatever. That would just be as progress. You think about it as where would you put the patient's story with an adult? It would be the same thing. I just don't know how to embed that drawing. I too thought, can't we just scan this in? Can't we just do this like an X-ray or, make it available in a file or something? It was like a little bit of a challenge. Like, where would that be? How would you access that? Or only who has access? I think it's like who has access then to this, and who would draw it back up?
It's like every informatics problem. The technology is the easy part. The challenging part is how to get it into the record, what metadata to associate with it and so forth. I'm kind of joking, showing my phone around because you could very easily take a picture of it, but there's much more complex issues than just the bits that you capture.
And that's usually when I say, I just take a picture. The kids I had to get an iPhone because they were disgusted. With my old phone, they said, put that brick away. I mean, kind of thing. But, the idea is that just take a picture of it. And then they said, no, you could do better with the scan. So they have that whole thing. But, that's there. Where do I put it? How accessible it is? And I always say, when I'm writing a grant or something, I just say, and then it can get, and here's the great thing, it's uploaded directly into the electronic health record. But I know that little one-liner comes with this whole background. And that's really, it sounds like a very simple thing. So part of my challenge is actually getting people to do this and see that it's easy and that it's informative to get people, because people dismiss, just like that little Prince drawing. It's easily dismissed, and children are easily invalidated for what they say. Like, I don't know how to, but if they had this experience, once they do it, I don't think people ever turn back. It's just getting people to try it. That's one challenge. The other challenge is they'll say it takes too much time, or how complicated is this, or we've got enough problem with these records already. But if it could be at the same time integrated, so that's really was my whole, challenge to that. I can say it's easy because I can say, could you do this, make this miracle happen? So, yes.
So I'm interested in the narrative piece and how much narrative is enough to go into the record. Let's just say that it's text in some way. How do you decide now how much narrative is enough to put in?
So when I've done this in research, as I said, I've captured the whole narrative. With Camtasia, where it's embedded and I get the whole story. And it would be nice to have the whole story, just like you have the patient's whole story. But as a clinician, when I put on that clinician's hat, I'm constantly doing that, whether I deal with a parent, adult, or a child. I'm constantly, saying, tell me your story, and then I write down what I took from that story, those bits and pieces. Oftentimes what I'm trying to do is, this is how the child describes something. If I'm doing pain, it's pretty straightforward. If I'm looking at, something more complicated about their, like an emotional experience or their fear or something, it's a little bit bigger chunk of that. But most of the time I'm paraphrasing what they have, and I've saved the whole chunk of what they have as a reference. So it would be great to have the whole story, you know what I mean, the whole narrative, if I could capture the whole thing. But in reality, it's not what people do. I get it for the purity of research. I always do that. And pull forward, so if anybody wanted to audit that or look, or if I go back and think, ooh, I didn't think about that before, I didn't pull that word forward. I have the entire transcript. Is that necessary for practice? I don't think so. Just like I could listen to your whole story about headache, and I would write down, patient describes, throbbing, unilateral, we have terminology that we use. This step for me is just getting the child to give me in their own words so that I can then put it in our speak, rather than asking the child to participate in our speak, which is what we do now. And the only thing we have that's at least remotely friendly for children is an intensity scale, which is totally inappropriate. It's far beyond their skill level, and we wonder why we don't. I mean, people say, oh, yeah, it works. And the children will tell you, if you have kids with chronic pain, you have to answer here if you want medicine. I don't know where to put it, but I've noticed that you have to do this, and they tell each other, you have to give at least a 5 here or 6 here if you want the school nurse will only give you your medicine if you do a 6. So, I mean, they've learned to work around that tool, but I don't know that it really captures. And intensity is such a small part of pain, of the pain experience, especially in chronic pain, because intensity kind of goes out of those things. So, particularly looking at it right now with chronic pain and chronic symptoms. But you can do it with asthma. We've done it with asthma symptoms. What happened here? Can you, So. Yes?
I worked in a behavioral health study for children once, and we had a paper chart. But the paper chart had a separate section for, we call it debriefs, where the child would either write or draw, and we'd store that. And use it for the next debrief. And I could see doing something similar for, at least where I work, we could just set up, literally, if we had agreement for the practitioners, we could set up a separate section for that.
Yeah, it's an interesting point, because at one point early on, I had asked, not this group here, but when I was at Iowa, I came here from the University of Iowa, I said, where is the kids chart? Where is this kids part of this chart where we could have stuff in here that the kids bring from home or whatever? Like, where is this child's voice? How do we get this voice? Because they are in this patient-centered care. And I had said, could we maybe have a section? And we were dealing with paper charts at that particular point, so you had that. I mean, in my own charts, when I had my own practice, there was a section right in the front. So the very front, you could see the drawing. Every child coming in had to do a drawing. And they would come in, where's my drawing from last time? Or something like, they just came in looking for it. But, and so right away are engaged in that whole process that you're sort of interested in. So the two things they had always for me is, what book are you reading? And where's your picture? And they learned that, especially in well child care. And you see the headline today in the American Academy of Pediatrics that says that children should be read to. And I'm thinking, hello? That's been, that we've known that for, that research is way old, but it's so good that they're doing it now, that they've made that mandate or, suggested. But that was like in there, and that was a section right up front. It wasn't a separate section, but I thought, how do we make the chart, the child's chart, child-friendly in that sense, or sensitive to the child's needs? That's what patient-centered care is. It's engaging the patient in the care. And we are trying to become more friendly to adults that way, and we have this whole thing, but we have not quite taken that step with children. And this is just one piece. So a section in the chart might be good and might help, people could access that who are willing to access it. I wouldn't call it necessarily only behavioral and developmental, but I get that if it was a particular study, but a separate section for the kids themselves that they could access, or that is accessible and, again, readily accessible. So. Interesting, yeah.
So there's a big effort right now to make charts accessible to patients. And it makes me wonder, as a lab tech, what that means in terms of translating into clinical ease to patient ease. Now we're talking about children. Yeah. So the question is there a role for a patient-owned chart that's almost a diary or a log that selectively shares information with an electronic record? Or are you thinking that the electronic record should really serve both purposes, that it should look and feel usable to patients, children, and elderly included?
Those are great things. I'm not thinking any. I'm only thinking that, how do we do this? How do we engage children's voices more in care that is around them? And I find when I had a paper chart, I could do that. As we've switched to the electronic health record, it's become a challenge for me. I just can't get my head around where I put this in and how the ease of access. But I'm having trouble ease of access with the electronic health record, sometimes getting other things too. So it's not just that. But the idea of a patient record a parallel chart. I mean, I shouldn't use that term because that's a narrative term, but people, keeping a parallel chart. I think physicians and care providers right now are trying to keep a parallel chart themselves. So you're going to have a whole other group of people coming to you as informatics people to say, how can I do a parallel chart, of writing my reaction to this patient that doesn't belong exactly in the record, but I wanted to communicate to other people. In essence, that's the same challenge. It would be another challenge, but something to think about what other people might want to do this. I know the opening of the chart to patients is really quite something, because when you see a lab report, if you've ever seen one, sometimes it's like, and my whole work in genetics is about incidental findings. And so when you have an incidental finding in a genetic study, do you share it or not share it? Is it clinically applicable? Who are you to judge whether it's applicable or not? Especially if you find you've done a genetic screening like we do on children right now with the developmental delay, and we find a couple other things that may be an adult onset disease or something, because we know beforehand we're going to find it, because now we do a whole segment. We're doing exome testing. I mean, we don't just look at one gene or one little thing anymore. It's like in the past when you wanted to know a sodium, you could order a sodium, but now if you want a sodium, you get a Chem 23. So when the patient looks at that, they can say, well, what's this over here? This looks, and you're not paying any attention to that, or it's not really relevant to what you're doing, and it could be off a little bit, but the patient gets that information. So we have incidental findings, and people have looked past them, but I think that whole parallel ethical decision around opening charts is there, and who makes that judgment, what information is shared and not shared. And we do a lot of that, what we call paternalistic decision-making with children, and even with their families. And then we have that parent. Somebody brought up, and it may have been you, Dan, about the parents and sending something from home. That is also a challenge, because the parent does have to approve. You can't not. I went into pediatrics because I'm really not an adult person. I really like kids. Unfortunately, kids come with adults. I forgot that little piece. But the thing is they are a gatekeeper, and so you must engage. But I have yet to find a parent who did not appreciate the engagement of the child, or to use this and come back to it, or say later, gosh, I was way off. I never heard that, because I always said, is it like a lightning bolt or something? Is it like this? Because that's their own experience. And so,
great
you want to put that last slide?
and conversation. Yeah, and thank you, Dr. Driessnack, for coming and spending time with us today. You can tell from the engagement of the group that this is something that's got people really thinking. And so I just wanted to touch in the last few minutes that we have and just make people aware, if they're interested, that AMIA, for this is their second year that they're sponsoring a student design challenge. And this year it's titled Beyond Patient Portals, Engaging Patients with Their Healthcare Providers. And Erin, I think, had the bright idea, after having spoken with Dr. Driessnack a couple of times, that her problem might be a good challenge to try to tackle for this. It's not the only problem that we would have to tackle, but what I'm in the process of doing is gathering names of folks who might be interested, either faculty advisors or students who might be interested in participating in this challenge, and putting together a team specifically to address her problem. Yes?
Can I recommend bringing this to Judy as part of our interoperability class, as maybe either a case study or as some course content that might bring out some students?
What'd you call that? Interoperability?
Interoperability, because Bill is exactly right. This isn't just a technology problem, but getting something from an iPhone into an electronic health record is what that class is kind of about, not just hospital to hospital, lab to
I've
hospital.
just never heard the name of that course, so it's a great title.
I'm
so used to
it's desperately needed.
Pediatric primary care or something like interoperability. Sounds much more engaging. I might have to take that.
Oh, really? So it's this summer?
Sorry.
Late summer? Okay. Andrea, do you know?
Are you pushing your button?
Right. It's an extended abstract, yeah. So as you can see, the abstract is describes the challenge, a proposed solution, and the design process. So there's a lot of work that needs to happen between now and August 1st, and then you can see the timeline. 8 will be selected to present posters at AMIA, and then 4 of those will be selected to give presentations, oral presentations at AMIA, which is in November. So if you're interested, or you think that there might be somebody who's interested that you know, please feel free to refer them to me. They don't have to be here in Portland, all you folks out there. We also have already somebody who's interested who's in LA. We'll work the team virtually as well as live. And we're going to hold an organizing meeting next week on the 2nd. So just shoot me an email if you're interested, and I will add you to that meeting, and then we can talk about this challenge as well as any others that people would like to address, and figure out how we'll proceed from there. It would be a busy July, so you need to be willing to pitch in during that month, but otherwise I think it would be a great experience. And we would maybe help you take a step toward solving your problem. It's really fun to work with you. I can vouch for that. Thank you very much. Thank you very much.